So we're now moving on to the last, but certainly not the least, presenter this morning before our lunch break. Dr. Suzanne Zinc is an assistant professor in child and adolescent psychiatry with the Department of Psychiatry at Dalhousie, and she works both in the Bipolar Disorders Clinic at the IWK and also the Halifax branch of the IWK Community Mental Health Clinic. As you can see, she's presenting on a topic which we certainly see with increasing frequency in the headlines today, and that's with regard to suicide in adolescents. And I'd now like to turn things over to Dr. Zinc for her presentation.
Thank you. It's an honor to be asked to present at the academic day. And looking around the room this morning, I realized that I'm not sure I'll be teaching many of you anything, but I welcome the opportunity to present these all in one set. So I have no disclosures to declare. As Dr. Milliken just said, suicidal ideation is very common. And our task in an emergency setting is to determine the risk once someone presents with that. It's important to know that emergencies arise in every practice setting. We're talking today about emergency rooms for the most part, but in inpatient medical and psychiatric units, this can occur. Outpatient clinics, it's very common. We don't know when someone comes in for a booked appointment really what's going to happen, and we need to know what to do next. And also in day and residential programs, and Dr. Junick presented recently on this at the clinical rounds at the Department of Psychiatry on managing it within day and residential programs. So there is a different focus depending on the clinical practice setting, but hopefully today you'll come away with some idea of the risk factors that are common across the settings, and as well more specifically for ER and outpatient clinics, some strategies to help someone move through this therapeutically. So as you can see that many teens present with this ideation, and those who are depressed, 50% of them will actually attempt in their lifetime. So it's not something that, although we're very familiar with, we need to kind of treat routinely, and very few of us do. A few other quick facts. Attempts are much less common than ideation, but they still occur quite frequently, depending on the study, anywhere from 1.5 to 10% of girls and 1 to 3% of boys. And it has a high impact. This is from the Youth Risk Behavior Survey. 20% of high school students seriously considered attempting suicide. So that certainly reflects, if nothing else, a high level of distress in 1 in 5 high school students. And 15% made a specific plan, almost 10 made an attempt, and 2.6 made a medically serious attempt. This is also a problem that is not only in the press, but epidemiologically, we're seeing it more and more presenting, and there are a variety of hypotheses on why that is the case. Increased awareness is probably underlying a great deal of this, which is a good thing, but as we all know, as practitioners, the resources that are trying to respond to this increased recognition and help seeking aren't always adequate, at least in the configurations we've been using, and that's one of the things we're responding to. So just to reflect this with local statistics, there has been quite a large increase in the IWK psychiatry consultations for suicidality, and for any reason in the emergency room, but the primary is that. In 2009 to 10, psychiatry consultants or residents saw 371 ER patients, but by 2013 to 14, it had doubled to 792 over a period of those years. And it's important for those who are here to know that this does not reflect an increase in the crisis RNs and social workers contacts. So this doesn't include that data, and it's also proportionally going up, although I didn't have the numbers to share with you today. So those who are seen by psychiatry here are already, most cases, we heard about the exceptions today, but most cases are already assessed by a skilled crisis intervention worker, which reflects, again, the severity. So when we talk about risk assessment for self-harm, it's important to know what we're talking about. This is defined by the UK National Institute for Health and Clinical Excellence, which Dr. Harris just spoke about for his guidelines for delirium. They also have guidelines for the management of acute and chronic self-harm. And they define a risk assessment as a detailed clinical assessment that includes the evaluation of a wide range of biopsychosocial factors that are relevant both to the individual and, in the judgment of the clinician conducting the assessment, relevant to future risks. And so we tend to use a combination of individual and group risk factors to determine that, and to determine whether we're, able to let them go. So the main tasks they identify for the clinician are to identify and agree with the person who self-harms the specific risks for them. Both the method and frequency of current and past self-harm needs to be known. Current and past suicidal intent, access to means relevant to both the plan at that time of presentation and also medications that they have access to, even if it's not part of their plan. Depressive symptoms and their relationship to self-harm, because sometimes there is no relationship, and any psychiatric illness and its relationship to self-harm, because we tend to think of depression for good reason. It's the most commonly associated with completed suicide, but it's not the highest risk condition, however, in an individual. Specific factors preceding self-harm, such as unpleasant affective states or mood states, and changes in relationships. So it could be stressors or just a change. Coping strategies, do they have any? And if they do they use them regularly, and have they been effective? Significant relationships on a more chronic approach in terms of understanding whether they have someone in their life who's supportive or represents a threat. And other coexisting risk-taking or destructive behaviors, including impulsive sexual or aggressive behaviors. And then other risk and protective factors. Hope. Do they have hope? Do they ever think about that as a value or something to cultivate in their life, for example? And medication, which can be both a risk factor and a protective factor. So I'm mindful when I prepare this presentation that many here are physicians, specialist physicians, and then there are many who are non-physicians. So I try to focus the presentation on more the psychosocial interventions, but it is, as already discussed in the 3 talks, very important that we think about medication in terms of, what we're looking at. So for the physicians and RNs in the room and social workers who will be referring to physicians, I wanted to kind of expand on medication a bit. And so in terms of the one most commonly seen for adolescents who are suicidal, it would be the Ssri class. And many of you are aware that it does have a black box warning, and in the US an FDA warning, it's called that, about increasing suicidal ideation and acts of self-harm. And the reasoning behind that is that it can both activate in its early stages of treatment, increase the patient's energy and ability to do things while they're already depressed, but it can also have, it appears, a direct effect on cognition in terms of somehow, either through the prefrontal cortex serotonergic activation or some other mechanism, it can increase suicidal ideation or create it in someone who doesn't already have it. And so in general, it is something you need to be aware of, but particularly if someone has recently started on an Ssri. Over time, however, it does usually confer benefit in most people. So the number needed for one study, the number needed to treat depression and anxiety disorders is around 10, but the number needed to harm is 44, and that's not insignificant. When you think about the number of adolescents who are prescribed SSRIs, it's, when I present to pediatricians and pediatric residents, they're quite surprised. They still feel uncomfortable with that level of risk. But it is important to know that careful monitoring is really helpful. So the other classes to think about that are commonly used are stimulants, psychostimulants for ADHD, and also there's a huge list of medications that could contribute to agitation or activation, but steroids is another to consider, both illicit use and also youth who are recently started or stopped on a steroid regimen for a medical problem. So I'm going to present a clinical vignette, and I deliberately chose a child that did not have depression as a primary disorder. Anna is a 15-year-old girl who presents in the emergency room after an overdose of 30 ibuprofen 200 milligram tablets. She has been in follow-up with a psychologist receiving weekly trauma-focused CBT for 2 months prior to the visit, and had more recently begun a trial of fluoxetine under the care of a child and adolescent psychiatrist for treatment of PTSD. Anna gives the history that she has harmed herself with small overdoses of Advil and cutting her thighs with a razor blade for 2 years. At no time were these with suicidal intent. The self-harm began after she was raped by a boy while intoxicated at a house party. So many of you here will be familiar with a presentation like this. Would anyone like to shout out some risk factors that appear for suicidal ideation, suicidal completion? Feel free. If not, I'll go through them, okay? No one wants to work today, and I can relate to that. Pardon, PTSD, so the diagnosis itself, yes, and trauma, that's right. Anyone else? Just started on fluoxetine, yes. Anything else? Pardon? Yes. So did you say intoxication or drug abuse? Yes, intoxicant use, so substance use of any kind. Anything else? Past history, that's right, of self-harm. Although it wasn't with suicidal intent at any time or even suicidal ideation, it confers a chronic low risk, and it moderates risk later on. Any others? Pardon? Yes, that's a great point. Thank you, Terry. The start of cognitive behavior therapy for any indication, but particularly trauma, can actually induce worsening suicidal ideation. Not because the therapist is not doing a good job, but because they are doing a good job. The work itself is emotionally loaded, and it can cause a brief spike. There's a good study on that as well for depression. Anything else? In terms of management, the thing to be aware of also is that she has access to medication. Clearly, if she's taking small overdoses, she's either buying it or has it at home, and she may also have access to her Ssri. So that's just something else to keep in mind. So when we're hearing these stories, we have to keep many goals in mind. We want detailed information, but we also have limited time. And we want to increase psychological awareness in the patient and the family of the situation, including the thoughts, the feelings, and events, not just the stressor, if there is one. And family involvement and reactions we need to assess as well. What does the support or lack of it look like for this family? And what is its effect on the teen? Because sometimes parents who are highly supportive and nurturing can actually reinforce some of these behaviors and thoughts inadvertently. The mental status examination is where it's at when we're kind of assessing the intervention that we're trying to do in the emergency situation. We want to observe the affect and the reactions of both the patient and the guardian, if they're present, very closely. No change from the acute distress at presentation during the interview is usually a sign that there may be higher risk. Or an abrupt change with absolutely no indication of why that occurred is also something to be concerned about. But generally speaking, if you do see an opening up and a settling of sadness, distress, and a future forward thinking change and emerge during the discussion, then you're having a therapeutic intervention. And with all this, you need to make a risk assessment and safety plan and disposition decision. So risk assessment need not, oops, I was just skipping over the slide, sorry. There it all is. Risk assessment does not need to include a full diagnostic assessment, but a therapeutic interview is essential, and that's in order to really assess risk. Someone needs to be able to talk to you. But also it can treat, not just prevent in that time an act of suicidal intent or suicide attempt. Once the symptoms and stressors are understood, the clinic and the ER psychiatrist or therapist and family doctor could collaborate on a safety plan, including the use of the office supports versus the ER. And this is an important part, which is difficult. We heard today about many of the challenges in doing that, but for kids who have multiple risk factors, this is often time well spent. So we do use, I'm going backwards. How did that happen? There we go. So we do use a variety of self-harm and suicide risk assessment tools. Most community clinics and ERs use one. For example, the IWK CDHA use the Ssri form. They're really an aid memoir, which is meant to prompt us in case in an intense day or a dense assessment, we forget some things, and that happens. And it's not to predict who will attempt or reattempt, and not to decide who should be admitted or not. But if we scan at one of these sheets and there are a lot of tick boxes, that should just kind of help us make sure that we're paying attention to the interaction of those factors. The best tools are research and clinical practice guideline informed. Right now at the IWK, we've had a recommendation from an external reviewer to use a different form that's more relevant to the kind of risk that we're trying to assess in our emergency room. So that's why I deliberately today did not show you the other form, and also because some of you are from areas that may not yet be using it. So coming back to Anna, Anna tells you that she used to take 3 to 7 Advil on average once a month at a time. But in the past 2 weeks, she has taken 10 or 12 tablets on 2 occasions. She also has several cuts on her arms that appear to have been deep enough to require sutures, but are too old to suture at the time of assessment. She tells you that she made these 3 days prior to the overdose she took today, and you agree with that assessment, looking at them. She also tells you that she took the overdose after hearing her parents argue about the effect Anna's anger is having on the family. Does anyone still feel like shouting out risk factors from this new history? So she has identified that her chronic risk of self-harm, which someone already identified, is worsening. And for most youth who have this profile, we can tend to get very comfortable with it and forget that if there's an acute exacerbation of self-harm, even if someone's been doing it a very long time, if they have a spike in the intensity, frequency, or severity of the harm they do to themselves, that can signal higher risk for completed suicide. She also identified what could be a one-off stressor or could be a chronic stressor. Both are increasing suicide risk, and that's family conflict or fighting. She also has what she sees as an unsolvable problem. I didn't put that part in, but she sees her anger as causing a problem in the family, and she had no idea whether that would resolve. So for her, that's she's caught. She can't see a way out of that. So that's another risk factor. The other thing to consider is that she might have anger and impulsivity from the PTSD, most likely, but she could also have an underlying anger problem, and if she does, that also confers risk if she's impulsive from that. And the other risk factor, coming back to medications, not even addressing the chronic harm to renal function from the Advil, we'll leave that aside, but the other risk factor for psychiatric to consider is whether she's adherent to the Ssri as prescribed, because some are taking it, but they take it either intermittently or not at all. Or in her case, she might be taking small overdoses of that as well. And knowing what we know now about the SSRIs and what they can do to risk and activation, it's really important to create an environment where they'll tell you how they're taking that medication. Because if she's taking it intermittently, she may be actually putting herself at significant risk of agitation or activation. Another factor to consider, of course, is one Dr. Harris already spoke about, which is akathisia, which it can confer risk independently and does occur with the SSRIs. So those are the main risk factors at that point. So when you're exploring them, we talked about how you need detailed information. Frequency, duration, and content is something we don't always ask about in a detailed way. And I think it just comes back to, I'm not sure, it comes back to our natural human response that we don't want to reinforce a behavior by talking about it too much. But of course, no one here would avoid the topic completely, but it can be very important in assessing risk to really understand how long did that person spend actually contemplating suicide? What were they thinking about? How long did it take? Was it intermittent or was it continuous? And what did they actually think about doing in terms of what the act itself or the effect it would have afterwards? Were they thinking about that at all? Preparation, of course, we know is an independent thing to assess. Do they actually have means? Did they go out of their way to get pills or a rope or any of those things? Access to it after the fact is important to know as well. One question I like to ask, though, is, what did you do with that? Because a person who takes the pills off of the shelf, opens the bottle and sits there with a handful of pills, staring at them while contemplating taking them, that's a very different situation than someone who has the plan but never even walks to the medicine cabinet. And so it's important to get these details because I think it can really take you into how close that person was to taking an overdose or some other way of hurting themselves. Therapeutically, what they're thinking about while they're about to take it, it could be an important area of intervention as well, if not acutely, then shortly after. So the rescue potential, if they do make an attempt, is important. Do they drive into the woods and abandon their car and take the overdose there? That's a much higher risk than someone who takes it in their bedroom and then goes and tells their mom, right? Or more likely tells someone on Facebook. But it still serious, but it's much less risky. So the intent of the attempt is important. It does still happen that I see youth in Emerge particularly who take a serious attempt as an act of self-harm, or in the inverse, they take something that's relatively minor, but they're convinced it will kill them. So if someone does something relatively minor, in a small overdose, for example, or ingesting cleaner fluid in a small quantity, but thinks it will kill them, that's much higher risk than someone else. And then the inverse is true as well. You have to assess, even if someone is only likely to self-harm again, not commit suicide, if they're choosing lethal means, then you might want to keep them till they understand the impact of that. So the child's understanding of a stressor is very important as well. And again, this comes back to sort of accurate empathy. We're all trained to go beyond, the normal response to hearing about stressors, but it is really helpful to ask not just what we would generally think anyone would feel, but what specifically does it mean to that child to have that stressor? And also, a change in their symptoms itself can be a stressor. It can be a cause that can motivate more hopelessness, for example, but it can also be a positive factor as well if things are improving. Another concept is that risk has a time course. So the psychiatric and gender-specific profiles of the youth suicide attempters are actually quite similar to the profiles of those who complete suicide. Although I emphasized in the abstract that they're different, there are similarities as well. It's a complex issue because multiple factors, as we went through, have to be assessed. And it's also got a time course. So the acute on chronic risk, I feel, is a useful concept, and unfortunately it's not addressed in the Ssri form, but I think it is something to consider. Acute means at the time you're assessing them, so now. And chronic is the baseline risk. And so, for example, a past attempt increases chronic risk over time, but a current plan further increases acute risk. So that's something to think of. That's one example. So substance use disorder increases chronic risk, but intoxication or potential intoxication within the weekend after discharge, it further increases risk. So important to differentiate these things, add them up together. There is also a burgeoning research on the risk factors and their moderation and interactions, which is wonderful. A recent study by King, published in the Journal of Adolescent Psychopharmacology, revealed that adolescents who screen positive for suicidal ideation or attempt, plus depression and substance misuse, were the most likely to engage in a future suicide attempt. And from the risk factors, people have been kindly shouting out. I know you're already aware of this, but the study is showing what we suspected. So 40% had an increase, and in 2 months, 7.4% attempted, and of that, 18.5% had self-harm acts. And so previous attempts on their own confer risk as well. And 10% of the people we send home after a suicide attempt will try again in 6 months. So again, really important to see if we can intervene therapeutically. So I talked earlier about the mental status examination. What do we look for? So I spoke about affect changing throughout the therapeutic intervention. We want to know whether they're closed up, angry, tearful, or anxious. Is their mood congruent with what they're presenting, or are they actually saying they're fine and cheerful when they don't look so, or the opposite? Do they actually know their mood? Because being able to identify and use feeling and emotion words is another factor that can be helpful to them. It's something you can teach them. Sensorium, are they intoxicated? Are they sedated after an attempt? Speech is coherent or pressured. Thought content, do they have any stressors that we know about? And do they see them as solvable? And is their thought form flexible or rigid? Any symptoms of psychosis can increase risk. Do they have compromised reasoning ability? So someone with intellectual disability or social interaction impairment of some type, either an autism spectrum disorder or other, could be an important factor. Some people's just with typical development can be very rigid cognitively, as we know, and so that person would have difficulty seeing the nuances in some of their situations, so that could confer risk as well. And are they agitated with, either from their emotional state or for other reasons, or completely shut down and withdrawn? So when we're looking at a safety plan, it's important to know that this is not the same as a contract, which was very popular many years ago to try and get someone to sign a contract. They wouldn't harm themselves. And we know that these do not work. In fact, in some cases can be harmful. When I talk about putting a safety plan in writing, what I'm referring to is literally copying for your chart, but also giving a copy to the family of what can be done starting as soon as they leave the emergency situation, either ER or clinic. It would include things like the next appointment dates with the clinicians, either the urgent care service at the IWK or their outpatient clinic at the community, their family doctor. Any plans for graduated return to work and school? This is something that's usually very helpful, is to give, if the child is in school or working, to give them a bit of a break for 48 to 72 hours so they can process what they've learned in the emergency room. This isn't always possible, and some teens will reject it, saying that going to school is actually helpful for them. And in that case, of course, you wouldn't push it, but it's important to keep in mind that you can do that. You're not enabling the behavior in most kids when you do that. It's helpful. So you're trying to secure any lethal means if the acute risk is at least moderate. You would like to look at supervision or stressors, and I'll talk more about that. And the list of activities for distraction. This is very important. It's particularly important in depression, but it's very helpful in helping people get through a period of hopelessness or suicidality if they can come up in advance with a list, literally in writing, of things that they can go to. Once someone's already in a depressed and hopeless state, or a hopeless state for another reason, it's very hard for them to actually retrieve memories of anything that they find helpful. And so if they have a written list that's tailored to them, to things they can actually do in the short term, for example, read this book, watch this DVD, call this person, have the bubble bath in their room so they can take a bath at the time. Those things with a list can be very helpful in getting them through distraction, positive coping, and soothing. And where appropriate, if it's an interaction, can build closeness, get them out of that cycle. Obviously, the phone numbers for the crisis line and how they can return to emerge if they need to. And then the next part, which isn't as commonly used, but I really like, I find it useful, that's why, is a safety script. Now, before we go into the safety script, I just want to say that we do need to talk about linking the safety plan to the outpatient clinic. Because our time in Emerge is so time limited, we couldn't necessarily do all of these things, although I see amazing assessments where our crisis workers are doing all of this. But the way to increase that likelihood is to have things like positive activity lists already printed up that you can just pull out of your desk or filing cabinet. And you can even give it as a task to send away with someone who's in a much better place to fill it out themselves, bring it to their next contact. But the ER visit information should inform any subsequent office visit. So really, if you're working only in an outpatient setting, take the time to read those assessments. They can be very helpful as a jumping off place for your next contact. It can also prevent, irritation in the patient and the family, because you can show them that you've read it and you know some things about them, and you don't go over everything. But it's also helpful because sometimes in a crisis people will disclose things that they will not disclose once they see you in an outpatient setting. So using a screen of risk and stratification, using the known information about the patient, the family is required, so you can gather further and adjust as you go along. And if you do find that there's a newer repeat ER assessment needed, you can make that decision, or whether they just need a follow-up office appointment. So this is for the outpatient clinician. One thing that I do on a limited basis and very much dependent on the situation is phone contact. I do not do that in a high-risk situation, but I can if there's a specific stressor that I know is coming up within less than a week when I'm seeing a patient. I may often call them and ask them how that particular exam went, and always before that encourage them to use that support from within their circle that isn't professional. But sometimes it's very helpful, and that's obviously used a lot more in services like DBT, where the patient can call themselves. But this is something to put in your toolbox. So these are, tools that we can use. It's a balance of diathesis interacting with life events and other risk factors, the risk. So it's important to just also go, once you do all these things, to go with it's called intuition, but we all know that from studies, intuition for clinicians is actually guided by multiple cognitive factors and things they know, and it ends up sort of coalescing sometimes into a decision and a gut feeling. But if you have a feeling that there's missing information or something isn't fitting, usually that is a sign that there's something to reevaluate on your part. If you have concrete evidence that there's missing or vague information or ifs, those aren't part of a workable solution. So feel free to kind of come back to the patient and the family and say, things look better, but I'm worried about this area. And so that can be either part of a new solution, or it could lead to a temporary hospitalization until that part can be worked out over a few days. It's because the youth must have a supportive environment to return to after a suicidal situation or attempt, and they may need more work for that to happen. Several people actually spoke about the benefit of acute care observation beds in Emerge, and I trained in one hospital in the McGill system that had those, and I can say they were amazing because sometimes we did in-house calls, so I could see the difference in a patient I would admit at 11 p.m. at rounds the next morning at 9 a.m. So I think for some settings it's certainly worth considering. Urgent care services are kind of the more modern compromise to that, which are also very helpful. If you're in doubt, check your own reaction, and if the info and the support are missing, if you're coming from the outpatient, send them to Emerge, and if you're in the Emerge, send them to the inpatient unit. We try to avoid admissions at times, but it is important to know that while it can be a crisis for the family, very shocking and upsetting, it can also be a great opportunity for the family's system to be shaken up in a necessary way to find a new solution to problems. And I'm talking a lot about the family, but that's because I work with child and adolescent, but it's also a chance for the teens world to be shaken up and find out, what's happening. And I try to tell them about that, and also obviously answer their questions. That's a big part of helping someone get on board if there's an admission required, is just answering their basic questions. Sometimes they're worried about things as simple as, I'm vegan, I don't want to come in because of that. So just little questions about what your worry is to start with can be helpful. So when working with the adolescent, this is true of adults who are married or living at home, but we work even more closely with the family when we're seeing a suicidal adolescent. First factor is, do they agree with the assessment plan? And so the residents in the room will be very familiar with this, and this discussion with the staff they're on call with is what do you do when you know that sending someone home is okay, but the family is not in agreement? Generally speaking, the guideline for me is that if this was a suicide attempt, then I might be more inclined to recognize that the family not being ready is an important factor to treat. If this is recurrent self-harm and the suicide risk is low, we've determined that, I think putting more pressure on the family, and I mean pressure shared therapeutically, helping them understand why an admission for recurrent self-harm is actually possibly detrimental or not to their advantage, is important. But it can be very important, as I spoke earlier about family distress. It confers risk independently. If the family isn't supportive, family's just not available. Dad's on a business trip and mom is, working. It's going to be difficult to come up with a plan for observation during the day. So those are things to kind of figure in. Even if people are well-intentioned, I mentioned earlier, they can actually have high expressed emotion. So a high level of anxiety is something to help the families deal with. And that's where the family and patient safety script can be useful. And simply, are they able to implement a safety plan? We have to be honest with what families can and can't do. If one or more of the parents, one or both of the parents is suffering from a mental illness at the time of the risk assessment, substance use disorder, and working and busy, they may be full of compassion and all of the right intentions, but we have to be honest with ourselves and them about what could be done and what needs to be done. And again, sometimes in admission, that's part of what's being worked out. So I already spoke about some of these other factors. Physical illness is one I didn't mention. If you have a parent who's disabled, their ability to do some things just due to chronic pain, for example, could be a factor. So you take it all in. So the last thing I'm going to focus on in depth is the safety script. And this, how many of you use something like this, where you actually teach the patient and the parent or guardian a way to discuss self-harm? How many of you use something like that? I see a few hands. Raise them high. That's great. So not too many. So hopefully this will be of interest to the rest of you, and maybe those of you who are doing it already, if you're willing to share anything that you do that isn't on this list, I would really like to hear about it. So this is something that I do take the time to do when I'm in the outpatient clinic or discharging from the emergency room, particularly in depth when we're discharging from the unit, because that's quite a big transition. And that is in which we give a script to both the guardian and the child, and how that would interact with the clinician. Sometimes I draw it up as just a list, and other times, most often, I draw it up on an 8.5 by 11 blank sheet of paper, and I actually draw a little arrow between one column and the next, and one is what the parent asks, and the other is what the, it's a flow chart or an algorithm, and one is what the teen might say, and then the arrow goes back to the parent. And it takes no more than one sheet of paper divided into 2 columns, but it can help you really help the family communicate around risk, and can prevent sometimes some unnecessary or less than absolutely necessary calls to the crisis line or the return to emerge. It can also help build a therapeutic relationship within the family. So for example, the guardian would ask the child, this is a typical one, ask the child twice a day about mood. And if they get, my mood is low, it's bad, not happy, or no answer, then the parent is instructed to ask about self-harm specifically. Are you thinking of hurting yourself? Are you thinking of suicide? If the child is withdrawn, has incongruent actions, so they're showing agitation, or you see them walking around with pills that aren't theirs, obvious things. And then if they have no answer, the guardian is advised to call the crisis line or the therapist if they have an outpatient therapist, and or go to ER. So once there's a risk in a non-communicative patient or both, That's where the parent is asked to go. But so this is the part where it goes back and forth. So if they get a yes, that their mood is low, and a yes to I'm thinking about hurting themselves, if this is someone who isn't too distressed, the parents can ask, do you have a plan? Are you going to hurt yourself today or soon? And then if not, if there's no plan to act, and the parent is able to handle that, they can actually try and intervene and just say, what is going on? What's happening? Would you like me to stay with you? Why don't we do something together? It's very important to know, this is a condensed version here, but it is important to tailor it. What we're trying to teach parents and patients is that these things are different every time, but for an individual, they often have similar stressors, similar thought patterns, and therefore similar things that will be helpful to them. It has to be tailored to the individual, though. The child's task is to answer the questions of the parent. That's the main way I introduce it. And for the youth who are really refusing to interact with their parents, obviously if there's a lot of rejection or inability of the parent to meet their needs, that's a protective thing. But if it's simply just that communication is broken down, which is the most common, either lack of ability, lack of discussion of emotions, this can be helpful to rebuild that. So in those cases, I tell them your task is to answer your parents' questions. And that's easy to remember for them. So answers that are vague will lead to more questions. That's what I tell them. If you answer the basic questions, how are you feeling? Are you thinking of self-harm? You'll probably get fewer questions after. If you don't, that's where things might get difficult. But again, I say there are reasons why you may not answer, and so that's okay too. What we can do is normalize that. We can say, a brief answer, a one-liner, a one word is fine, but they may still get some other questions. Another common answer for depressed kids who are recovering is, I feel terrible, but I'm safe. So that's something they might say. And that's a signal to the parent to maybe bring in the positive activity list or suggest to do something with them. Because once the parent is no longer terrified, they can actually parent and move on with that. Code words are another one. A surprising number of teens like this. A very small number find it hokey. But sometimes you can actually come up with a code word that just means, I need to go to the ER, or when you need to call the mobile crisis team because I'm not safe and I'm thinking of doing something. It's so much easier for them than trying to spit all that out to a parent who is, just ordinarily busy or distracted with their other child, something. And so they can come and say cake or Christmas tree or something that I let them choose, and the parent, make sure the parent knows what it is, and it's not something they're likely to hear a lot in other contexts. And that can be very helpful. Quite a few take that up. And of course that will lead to a few more questions afterwards, but at least they don't have to pop out with the whole thing. And then after that, they're encouraged to try some of the activities that they can initiate on their own or the parent can do with them. And if not, to tell us when we meet next why it wasn't helpful or why it isn't helpful. Because again, that's where a plan breaks down or has glitches and doesn't break down completely is where you can find out more about what's driving the suicidal ideation and the behaviors. So it's useful working through these rather than throwing aside the script right away. Our task is to help the parent and child individualize the safety script, so we do have to kind of be open to that, to tweaking it, and to role play in the session. Another thing that people find hokey is to kind of, I'm going to ask you to say this to one another, but it can be very therapeutic. In most cases, people are very willing to practice it. If the teen will, if they think it's going to reduce, my parent's stressing out, and the parent is usually delighted that someone recognizes that they're just literally on the ceiling with anxiety. And that's the last piece of advice as a clinician that I give them, is that mom and dad or the guardian is going to be up here after an attempt, and you may be down here, even though you're the one experiencing suicidal ideation, because you know where you're at inside most of the time. Right? They don't look any different to the parent, and they may be very low risk. But the parents naturally are going to be up here for months, and that's therapeutic for them to just hear you say that, and that's why the script is useful, because they can assess that risk. And that helps you identify where the parents expressed emotion or biases about mental illness need to be addressed too, and depending on what you hear back. So do role play it. The role play helps because you find out if they have communication skills gaps and you can help them with that. Some people asking the question, how are you, is actually a really difficult thing to do. So you may have to coach them with that. And then help them identify relevant stressors they may not be taking into account. Some families live at such high level of stress that they don't even think of individual stressors as factors that can impact them anymore. So you can talk about that. And then reformulate and edit the script at each visit, as I mentioned. So you want to go back to that list of safety plan and center the script within that. Where does it fit? Where do you use it? When do you abandon it and come to the emerge? In terms of time, we're doing okay. So I just want to take a minute. That was a lot of information about the safety script, and ask people if they have anything they do that they would add to that, or things that they would never do that I did mention. Anyone want to throw anything out? Okay. So given there's time, I just wanted to bring up the references and practice guidelines. There's quite a lot out there, but in terms of recent guidelines, again, the NICE guidelines from the UK are helpful. If you go to their website, you will be able to download the PDF. It's quite long, but it's useful to read. It is for all ages, but there is a section on children and youth. The 2011 guideline is called Self-Harm Longer-Term Management, but it actually subsumes the recommendations of the 2004 guideline on short-term. So you don't need to read both. You can just go to the 2011, and it makes reference only to certain parts of the 2004. Another article that I've used for the risk factor lists here is Bridge and colleagues' article from the Journal of Child Psychology and Psychiatry in 2006. It's older now, but it's a good general summary. The ACAP, American Academy of Child and Adolescent Psychiatry, practice parameter is actually very out of date. Well, not out of date, just old. It's 2001. And again, many of these things don't change radically in 14 years, but what has changed is there is a lot of research into how the various risk factors interact and their moderating effects. So that's why it's important to have the guidelines updated. I'm going to skip over the question slide because I had put these slides in for you to review in case we didn't have time. But I'm going to hit the top risk factor in each slide before we go to questions. So psychiatric diagnosis, many of you threw out when we were talking about risk factors. 90% of suicide victims do have a diagnosis. And if there's an axis 1 disorder present, it's a 9-fold increased risk. So an illness with chronic course or severity imposes greater risk. The most common ones associated include depressive illness, substance abuse, impulsive disorders that decrease judgment, bipolar disorder. And this is important to know that it's not only in the depressed phase that bipolar disorder patients are at risk of suicide. It can occur with manic symptoms, particularly mixed states. Mixed states are very unpleasant, like someone described akathisia earlier. It can include a motor component of restlessness and impulsivity, and it's such an unpleasant state that many people do think about completing suicide. The lifetime risk of bipolar disorder, the depressed phase, is very different than the lifetime risk for major depression, even though they look identical. And we're kind of trained into thinking they're identical by the way their DSM-5 is structured. That if you read the criteria for depressive episode in bipolar disorder, it's the same as the criteria for a major depressive episode, which kind of leads us to think they're the same, but they aren't. The risk for bipolar disorder, for depression phase, for suicide risk is as high as 50%. That's huge. So when you have a bipolar patient in eMERGE, you have to think about that when you're calculating risk. A psychotic disorder, keep hitting the wrong thing. Psychotic disorders, particularly schizophrenia, confers a high lifetime risk as well. I'm not even talking about axis 2 disorders here, but generally for cluster B axis 2 disorders, lifetime risk is about 15% as well, just because there's so much. Gender. We know quite commonly that completed suicide is 5 times more common among males, particularly young males in North America. Where you live actually can affect this. That's an interesting fact to look at, depending on what access to methods you have. There is quite a high death rate in China among women compared to men, and the reason for this is that many women in rural China have access to lethal pesticides that the men are not using in certain areas, particularly because they're working outside the home. So this is one of the things that emerges, using a very highly lethal method, and that's the main gender gap across the world, is the lethality of the method, as well as probably some impulsivity differences. Sexuality, this is becoming more well known that suicide attempts and completed suicides are more common among youth who self-identify as gay, bisexual, or in terms of their gender identity as dysphoric or transgender. It's important to know that this risk is not a straight up risk, because people say things like gay people are suicidal. It's like, well, you need to think about this, but it's moderated by mental illness. So if they actually have genetic risk for depression, anxiety, and that's emerged, and they're identifying as gay, bisexual, anywhere on the spectrum of sexual orientation or gender identity, that risk is moderated also by the fact that it's hard to be gay, bisexual, or transgender still in some parts of our society. And so that is just a chronic stressor that person's dealing with. And so that interaction and moderation of that factor is important. So you want to inquire not only about orientation or gender identity, but you want to inquire about how's it going for them. Is there an area where it could be better? Ethnicity, Native Canadians are at the highest risk overall, but this is a very community-specific variation. So literally, depending on whether they live on reserve, off reserve, and which reserve they live in, it can actually increase or decrease risk. But do think about it. And then, of course, stressful life events. The most common precipitants for a suicide attempt are interpersonal conflict or loss. We're social creatures. If we feel alone, or if we've made an irrevocable mistake, then we're more likely to think of suicide. And then I already mentioned these in the mental status exam, the cognitive and personality factors. So is someone hopeless? What are their skills solving problems like? And are they having some impulsive behaviors? And of course, genetics. If there's a family history of completed suicide or a major suicide attempt, this does confer risk as well, so it's important to ask about. And then we already spent a fair bit of time on family functioning. The only thing I didn't mention is that attachment has emerged as a significant factor. It was kind of presumed but not really demonstrated. But in a recent study by McGregor and Journal of Clinical Psychiatry, it's been shown that insecure avoidant moderates risk severity. So someone who doesn't trust and also avoids problem solving is more at risk. And that makes sense when you think about what someone would do when they're hopeless, how they would find their way out of that situation. And the last two, socioeconomic status, surprisingly is not different among completed suicides, but attempters are more likely to be poor. So again, a chronic psychosocial stressor. And another surprise one for some is that a past history of physical abuse confers risk independently more than sexual or emotional abuse. But it is very important to ask about all forms of abuse, especially if it's acute. And so I'm going to come back to questions if we have time. And I want to thank you for your attention. Thank you.
So we do have some time before lunch if there's any questions. Can you go to the, okay.
Hi there. Over the years, there have been periods of time that there have been communities or pockets within communities that seem to have had an increase in suicide amongst adolescents and teens. And my assumption is that teens and adolescents respond or are more likely to respond to peer pressure, media. Is there any evidence that supports that, or is that an assumption on my part and probably the part of many others?
I think that's it is being researched. It's a complicated one because it can also reflect an interaction of a variety of factors. There's no question about the contagion effect for non-suicidal self-injury. That's been well demonstrated that if someone is inclined that way and already distressed, if they see pictures or if there's a rash of publicized self-harm in their high school, then again, you'll see that. I actually had that demonstrated one night. I was on call. I ended up with, it was a very busy night with 12 consultations, but 3 of them were from the same group home. That night there was an incident, and then as the night went on, in Montreal there were more kids coming in. So you can see that happen. For completed suicide, it's a bit more complex. So I think what's been done in terms of kind of in analyzing that is that if it's within a city, not within a particular high school or a large city, it can still be a contagion effect because of the news, and teens know each other through different networks. But it can also, I've heard a couple of experts comment on this and say that you have to remember that it's a low base rate phenomenon, completed suicide. And sometimes things cluster and they look like they're related. If you think about the meningitis outbreak in Nova Scotia, it's so provocative. I mean, how can they not be related? Right. But sometimes we do have to consider that there are people who are in extreme distress. But again, contagion can be important there. If someone is just hanging on and they have very little hope and they're not yet connected to services, then it can be important. But I think we do need to be honest with ourselves. If there has been a community or an area of the community that's having a cluster of cases of suicide attempts, we should look at our services and see if there's a gap somewhere in that geographic region, for example, or if it's as simple as, a connection between services.
And is there any belief about or any thought about going into the schools if there does seem to be a cluster? Like, is there any evidence to suggest that kind of an intensive intervention within that area does anything to support the adolescents, or could it potentially make it worse?
Depends on how it's done.
Okay.
In the Purple Journal, the Canadian Academy Journal of Child Psychiatry, in the last, someone here will know, was it 3 months ago? There was a good review of suicide intervention programs in schools, and so you can look at that. That's both for prevention and intervention. We do know, though, that critical incident stress debriefing, which is used for any type of critical intervention, actually can worsen symptoms of PTSD. Yes. That one's kind of trickle down to everybody. So, but it's important to know that these types of interventions could actually become that if they're not done properly. What is helpful is support of faculty in the school, so helping them obviously manage their own stress around the things, but also how to identify and refer teens rather than kind of doing a whole school intervention.
Okay, very good. Thank you.
Thanks.
Hi, it's really nice talk. I was just wondering if there's been research or initiative to look into engaging with the new technology, the texting, the groups. This is something that's been quite useful in the drug abuse. Not everybody likes the group, meaning face-to-face of, let's say, Alcoholic Anonymous or Narcotic Anonymous, but in the clientele that I see, particularly with opiate abuser, it's very similar to, let's say, want to kill themselves or when they want to get high or get numb to just obviate the stress. So it's almost a peak of acute stress that prompts them to either inject with heroin or then just swallow a bunch of pills or to commit something. And then if they can just hang on and have a discussion in a safe zone. So there's texting and online chat groups is something that are monitored by somebody. We can just go in and log in and maybe it's easily accessible, but it's a young generation that's very responsive to these devices. And I was wondering if that you knew of initiative or research.
I'm not aware of any specifically cell phone based initiative, but I think it's a great idea in the sense that that's the medium that a lot of teens use. In fact, many teens that I see in outpatient clinic do not even have telephone minutes. They only have texting capability on their phones. And so I can think of many limitations to it, right? Because phone is already a step down from mental status assessment. You can't see the patient, but you can hear them, and that's kind of more information. Whereas texting, you don't get tone, you don't get that. But if as an initial point of contact, I think it could be very valuable. Now, there's websites that do it, right? There are places where people can log on and get live support. Generally, I'm a bit out of date on those, but when I was looking at them in 2006 and 2007, most of them, though, have a kind of a stopping point when someone starts expressing specific plans, then that person either calls them through a crisis line or encourages them to call the crisis line, just because there's only so far you can go online. But just the only one because I'll mention, because I'm familiar with it more, is that there are apps now, though, for therapy interventions for anxiety and depression, and those are very popular. They're used a lot by both adults and teens, and so I see a potential for what you're talking about, but I'm afraid I don't know of any program.
Okay, thank you.
Thanks.